That explains that. I have no idea. Anybody on Zoom, Lee? 2 people on
Yes,
Zoom.
we're here. Can you hear us?
All righty.
Can you hear us?
We'll wait 5 minutes.
Hello, Dr. Kaur.
Hi. Who am I talking to?
Oh, hey, it's Tracy.
Oh, hi,
I was
Tracy.
just making sure. Yeah, it looks like myself, Ellen Valadez, and Dr. P are on Zoom. I don't see anybody else on there
That's
right
fine.
now.
It might be a small group, which is just fine. Or everybody already knows this stuff and there's some recent changes in the last year, but honestly, Alzheimer's hasn't really changed in the last 10 years until the last year. Last year, things got a little interesting, but. Yo. Thank you.
It slides right off.
Oh, yeah, just leave it on the table then. Thank you.
You're welcome.
If I don't use the water, can I just leave it unopened and somebody else can drink it? Perfect. It's 12:05, so I thought I'd go ahead and get started. I'm going to talk about dementia and Alzheimer's, no disclosures. I'm going to talk a little bit about the history of how we've talked about dementia. It used to be based on what psychiatry thought dementia was, the DSM. It included neurodegenerative things like Alzheimer's and Parkinson's and such, but they also included things like HIV, traumatic head injury, substance abuse. They specifically excluded delirium. So it wasn't always neurodegenerative issues. And then they had a different diagnosis called dementia precox, which I guess it meant pre-senile sort of dementias. And that was kind of lumped together with schizophrenia and bipolar, and also a neurodegenerative illness like Pick's disease, which we now call frontotemporal dementia. And then there was another DSM concept. There was another DSM concept called cognitive impairment, not dementia, or CIND. And so those were the terms that were used for a really, really long time. In 2003, the Mayo Clinic decided to use their neuropsych testing to refine CIND better into something they called mild cognitive impairment. And it meant they had to have at least one area of impairment. It could be memory, could be language, could be visuospatial, but it had to be at least 2 standard deviations off, and they had to be independent in their daily affairs. So once you have them diagnosing mild cognitive impairment as such, now we've used the term for dementia as they have to have 2 areas of neuropsych decline and a loss of independence. So from 2003 to about 2011, this is how we used to diagnose dementia. So still based on DSM with a mix of this Mayo Clinic. The reason why this is important is because we realize that dementia is sort of the end stages of a disease that's actually probably been going on for about 20 years. And so there's got to be these other time periods where people are normal, but the pathology is sort of developing over a very slow period of time. And then there's a transition phase, mild cognitive impairment. I'm going to come back to this diagram in a lot more detail later. But that was the main reason why we needed to differentiate dementia and mild cognitive impairment a little bit more. Then comes the DSM-5 in 2013, and psychiatry basically got out of the dementia game. They no longer officially have a diagnosis of dementia in the Diagnostic and Statistical Manual. They now have the term major neurocognitive decline. So if you order neuropsych testing, you're not going to see dementia, you're going to see major neurocognitive decline, impairment. Then they also have mild neurocognitive impairment, and the basic difference between those two is the loss of independence. They still have a separate term for delirium, but I will say that dementia still gets thrown around quite colloquially and casually amongst the psychiatry notes that I read. So they're not really sticking to their terminology very well. The way I like to define dementia is based on these criteria. The National Institutes on Aging and the Alzheimer's Association convened some roundtables in 2009, and they established 4 different work groups. They refer to a dementia phase, I like to call it a dementia syndrome, a pre-dementia or mild cognitive impairment phase, an asymptomatic or preclinical phase, and then pathology. We needed these criteria because we had to accommodate some of the newer testing and biomarker methods of diagnosing the different types of dementia. But they also had to recognize that outside of academic centers, they weren't doing a lot of spinal taps and PET scans and quantitative MRIs and such. So they had to kind of keep the criteria flexible enough so that they're actually clinically relevant, so that people outside of academic centers could still use these to diagnose dementia. And that's how we ended up with the 2011 NIA-AA criteria that you may or may not see in some of my notes when I reference that. And that was updated in 2018 with what's called the ATN Framework, which I'm going to talk a little bit about later. So these are the criteria we're going to talk about. And again, why are these MCI and preclinical stages important? The current projections are that 12 million people will have dementia by 2050. That's an awful lot of people. And we know from animal models that disease-modifying therapies are more effective early, not late in dementia. I like to tell my patients and their families that we've cured Alzheimer's disease in mice multiple times. It never works in the human brain because the human brain is complicated and we don't find this till it's too late. Like I said earlier, dementia is the end stage of something that's been going on in the brain for about 20 years. If we could delay the onset of dementia by about 5 years with effective preventive strategies, we would have a 30 to 40% total reduction in healthcare costs. Just think about how many people we see in the hospital who have cognitive impairment who would probably not be there if they could be doing a better job with their medicines and so on and so forth. So based on the new criteria, the way we define mild cognitive impairment is either the patient or the informant can report a decline. You as the physician, if you know the patient well enough, could also report a decline. There's got to be a clear impairment in at least one area of cognition. Doesn't have to be based on neuropsych testing, doesn't have to be based on standard deviations. It's 2 years to get neuropsych testing in Chattanooga right now. So if we were to wait 2 years, we'd miss a whole lot of people. So just some evidence of clear impairment in at least one cognitive area. And you have to think about their age and their educational and cultural background. Here's another story I tell a lot. I have had patients who are completely demented based on neuropsych testing who've scored 29s out of 30 on the MMSEs. I have had patients who have scored an 18 out of 30 on an MMSE and been completely normal on neuropsych testing. So it's got to, and that was because they had less than a high school education and English was not their first language. So you have to think about their background before you interpret cognitive screening. The other key part to the diagnosis of mild cognitive impairment, according to these criteria, is that it's got to be neurodegenerative, not medical, not psychiatric, very clearly not psychiatric. In theory, not trauma and not vascular, though you can think of degenerative traumatic brain injury like CTE as a type of dementia, and I do. And you can think of degenerative vascular conditions such as cerebral amyloid angiopathy. So there are degenerative conditions that are traumatic and vascular in etiology that could be considered a neurodegenerative mild cognitive impairment or dementia. But a single traumatic head injury, a single bad stroke, not enough to call it mild cognitive impairment or dementia in these criteria. Not saying they're normal, just not what we're talking about here. They can have some mild issues with instrumental activities of daily living. They could take longer, they could be less efficient, they could be more prone to error. But on a daily basis, they're able to maintain their independence with minimal aid or assistance. Ultimately, the distinction between dementia and MCI is this question, and it is not black and white. And neuropsych testing isn't going to help us here. I don't know how many people in here have done the training for the modified Rankin scale for doing stroke research in clinical trials, but if you have, the nice Scottish gentleman who's on there who's doing the interviewing, the video shows him asking a really interesting question that I decided to borrow for my clinic. And that question was, if you left that patient alone for a week, how do you think they do? And if the interviewer, the informant, the interviewee or the informant said, they'd probably be okay, then I use the diagnosis of mild cognitive impairment. If the person hesitates and they're not so sure they'd be okay for a week, they'd really want to check on them daily or every other day, then I say they have dementia. This is just me personally. Nobody in this room has to do that if they don't want to. You can find your own way of differentiating between MCI and dementia, but this is how I differentiate it. I ask the 1 week question. Would this person be okay for a week? It doesn't have to be perfect. It just has to be generally good enough for a week. But it does require somebody who knows what their baseline ability is. If you've got some little lady who moved from Guatemala when she was age 60 to live with her family, she never learned to drive, then that's different. Or she never paid bills in the U.S. These things matter, but based on their baseline ability, whoever knows that as best as possible, ask that question and see if that helps you differentiate. So now that we've talked about mild cognitive impairment, dementia now is cognitive impairment that interferes with function and usual activity. That is a significant loss of independence. And it's detectable by history and testing. Again, do not use cutoffs by themselves because they're not very helpful. You have to actually do the work of getting the history. And again, the etiology needs to be neurodegenerative. So the standard evaluation for dementia, we still rely on the American Academy of Neurology practice parameter from 2001, which is very badly out of date, and I think they're in the middle of updating it, but it's still officially, as of last week when I updated this presentation, it still has not been updated. These are still what we're supposed to do. Some sort of cognitive screening, some sort of dementia, depression screening, an MRI of the brain, non-contrast. There's really no reason to do contrast imaging. The only reason why I would ever do a CT scan is if the patient absolutely refuses MRI, or if they've got one of the older pacemakers that are not MRI compatible, or they're just so claustrophobic that they would need to be under complete anesthesia, then I might go with just a CAT scan. But really, I just skip the CAT scan and go straight to the MRI. B12, thyroid, CBC, CMP. There is no role for routine ApoE genotyping, genetic testing, EEGs, contrast imaging, spinal fluid, volumetric MRI, or PET or SPECT. There's no reason for any of it. You don't need it. And I very rarely get them. It's not very common that I get these tests. You want to be able to, I like to be able to answer these three questions for my patients and their families. Is there a memory problem? Is there at least one area of cognition, whether it's memory, language, executive, visuospatial? Is there at least one area of significant cognitive decline? Is it a dementia? Can the patient function safely and independently for about a week? And is it Alzheimer's disease? So next we're going to talk about Alzheimer's disease, described by, don't ask me to pronounce his first name, Dr. Alzheimer in 1906. He described that pathology in somebody who had presenile dementia at age 51. And what he found under the microscope were what we think about as the plaques and the tangles. The tangles are made of tau protein, which are inside of the brain cells, inside of the neurons. And the amyloid plaques made of beta amyloid. It's not the same amyloid that's in cardiac amyloidosis and so on. It's a different type of amyloid. And this exists in the extracellular space and the synaptic spaces. So it tends to disrupt synaptic function. The term Alzheimer's disease, as Dr. Alzheimer's used it, was reserved for people under the age of 65. Anybody who was over the age of 65, they just called it hardening of the arteries. So when we're getting our family history from our patients, ask them, did anybody ever get diagnosed with dementia or hardening of the arteries? Because that's part of the family history, and they just didn't call it dementia or Alzheimer's back then. Later on, we started using the term senile versus presenile dementia of the Alzheimer's type. Then in 1984, this alphabet soup decided to call it probable versus possible Alzheimer's disease. And basically that meant probable meant classic Alzheimer's disease, and possible meant, well, maybe it's Alzheimer's, but maybe there's a history of stroke or some Parkinson's or something else going on. We don't really know what, so maybe it's Alzheimer's, maybe it's not. It assumed that there was a correlation between the pathology and the clinical presentation. It's a big assumption. We staged amyloid based on CIRAD and tau based on BROC. I'm not going to go into a lot of those details because I'm not going to do a pathology lecture here. I'm happy to help give anybody who wants it any other information they'd like. But we basically stage the amyloid plaques and the tau tangles. We marry it with the clinical presentation. And that's called the NIA-Reagan criteria, and that was definitive Alzheimer's. So the only way you could have definitive Alzheimer's disease was if you had pathology. Until the time of death and the autopsy, it was probable or possible. There was no way to know definitive Alzheimer's disease other than autopsy. So that's when dementia of the Alzheimer's type evolves into Alzheimer's disease. Lots of problems with these criteria. Number one, normal people died with Alzheimer's pathology. There are lots of people who are normal to the day they died, and they are ridden with plaques and tangles in their brain. There are dementia patients who died with nothing wrong with their brain. Nothing at all. No frontal lobe, no Lewy body, no PICs, no strokes, nothing. Completely normal brain, but they met all the clinical criteria for dementia. You can have atypical presentations for Alzheimer's disease. We used to think Alzheimer's was just memory loss. Well, now we know there are primary progressive aphasias that present like Alzheimer's disease. There's posterior cortical atrophy, which looks like a visual spatial kind of Alzheimer's disease. So you don't have to have just memory loss causing Alzheimer's disease anymore. And now, as opposed to 1984, we know about other types of dementia. We know about PICs, we know about Lewy bodies. So there are all these other different types of dementias out there that 1984 just ignored. We have spinal fluid, we have MRI, we have PET, we have genetics. Bottom line is that there's a difference between having Alzheimer's pathology and clinical Alzheimer's disease. So I'm gonna talk a little bit about these biomarkers, and I told you I'd come back to this slide. This is the amyloid hypothesis of Alzheimer's disease. And again, what it points out is that dementia is the end stage of a disease that's been going on for about 20 something years before they ever have clear dementia. It starts with amyloid beta accumulating in the brain very slowly over a long period of time. After amyloid beta gets to a certain threshold, we start to hyperphosphorylate tau. The tau starts to collect inside of the brain cells and starts killing off neurons. Eventually, you lose enough neurons that you start changing brain structure. We start seeing shrinkage in the hippocampus. We start seeing shrinkage in other areas of the brain. And then eventually, you start noticing some memory issues, some cognitive changes. But even then, somebody can have lots of cognitive issues, but they're still functioning pretty normally. The functional loss doesn't happen until much, much later. And that's when we call it a dementia. So we're talking about something that's been going on for a very, very long time. The amyloid hypothesis has come under a lot of attack recently, and it's for that exact reason that I said earlier. We've cured Alzheimer's in mice multiple times. It doesn't work in humans. And so people have just been ready to throw out amyloid hypothesis because we haven't been able to cure it, and we haven't been able to help humans. And I understand that, but I think personally, what we really need to do is target this preclinical phase. The problem is we can't see that. How are we gonna give spinal taps and genetic testing and all these things to 50-year-olds? Probably not. So I think that's the reason why we can't seem to cure this in humans, because we're missing the majority of the disease when we can actually do something. So this is what the Athena test for CSF looks like. I actually kind of like the way Athena did it because they actually plotted out on this graph that kind of gives you an idea of where you are here. The Mayo, unfortunately, Erlanger moved away from Athena towards Mayo, and now they just give you the raw numbers of amyloid beta and phosphorylated tau and total tau and so on. I don't find it quite as descriptive, and that I like the picture so that I can explain it to patients better, but oh well, that's Erlanger's decision, not mine. They didn't ask for my opinion. But what we see in somebody who's normal, over here on I guess that's your left, my right here, is that the amyloid beta in the normal person versus the Alzheimer's patient, the amyloid beta level drops, the total tau increases, the phosphorylated tau increases, and the ratio changes, the ATI ratio lowers. So that's how we know that it's Alzheimer's disease. It's not definitive. It's still not 100% test. It's about a 90% test. And that's why I like this graph, because the graph actually kind of gives you an idea of the spectrum of change here and how it's not as clear. There's this quadrant over here that's not consistent with Alzheimer's disease. There's a quadrant down here that is consistent with Alzheimer's disease. But then there are these two quadrants over here where it's still not determined. So it's still not a 100% test, but it's about 90% accurate. And all this tells somebody is that they're at risk to develop dementia in the next 5 to 10 years if they don't already have it. Genetic biomarkers, the most common one we see is the ApoE genotyping. This is a polymorphism, it's not a mutation. And because it's not a mutation, it's not considered to be a true amyloid biomarker. It just increases and decreases your risk of Alzheimer's disease. And if you're homozygous, I believe that means you're about 50% likely to get Alzheimer's in your 60s. If you're heterozygous, you're 50% likely to get Alzheimer's disease in your 70s. But that's still not a 100% test. I actually had a patient once who came to see me for a family history of Alzheimer's disease. And she tested positive for ApoE. She was in her late 60s. And the reason why she wanted testing was because she was getting married and her new husband, she was getting married at 68. And her new husband his wife had died of Alzheimer's. And so she had wanted to get long-term care insurance to protect him in case she got it because she had this family history. And her primary care decides to go ahead and order the ApoE genotype and she tests positive. I followed her for 5 years. She never changed. She was completely normal into her 70s. Completely. She could not get long-term care insurance because she had evidence of a genetic risk for Alzheimer's disease, which is why I almost never order this test because it just doesn't help. I can't really think of many ways this test helps many of my patients. So I advise them strongly not to get this test done. But anyway, it's a polymorphism, it's a risk gene. It's not considered to be an official amyloid biomarker for research purposes. However, there are mutations, and if you get a mutation, chances are you will develop Alzheimer's disease. They're all related to amyloid processing, the amyloid precursor protein, presenilin 1, presenilin 2, and they do count as an amyloid biomarker for research purposes. And so there is a trial called the A4 trial that is studying people who have these mutations to see if early monoclonal antibodies can actually change the trajectory of their disease and prevent them from getting Alzheimer's disease. Here's what PET scans look like. This is an amyloid PET scan and a tau PET. A tau PET scan's on top, the amyloid PET scan's on the bottom. A normal older adult who doesn't really have much of either. This is what that looks like. Here's a normal adult who actually does. Again, amyloid and tau is there before for 10, 15, 20 years before you ever have the first symptom. This is a normal older adult who has evidence of both tau in their temporal lobes and amyloid kind of everywhere. And then this is an Alzheimer's disease patient who has, again, amyloid really didn't change between the two. Tau may be a better predictor of progression. But that's what that looks like. There are FDA approved tau tracers and amyloid tracers, so it is technically available. However, they're not reimbursed by insurance. So it doesn't really help us here at Erlanger. You have to, I believe Emory will do an amyloid PET scan for somebody for $10,000. And Vanderbilt will do an amyloid PET scan, but only if you're part of a clinical trial. And the tau PET scan, I don't know where that's available anywhere other than research right now. What we can get is an FDG PET scan, basically a glucose molecule. And what we see in people who have Alzheimer's disease is that There is hypometabolism of glucose in the parietal lobes and in the temporal lobes. So that tends to differentiate Alzheimer's disease. In a patient who has regular red, white, and blue fee-for-service Medicare, you can get an FDG PET scan if you've hit you've checked for syphilis, you've checked for B12, you've checked for thyroid dysfunction, and you've done an MRI. If you check all those boxes, Erlanger will do an FDG PET scan for that patient. But again, they have to have clear red, white, and blue Medicare. If they have any of the Medicare Advantage plans, you can pretty much forget it. And the technical indication from the Medicare is that you have to be looking for Alzheimer's versus FTD. In FTD, you're going to have frontal lobe hypometabolism instead of parietal. I order an MRI in just about everybody, and I will ask radiology to do a T1 coronal for me, and so I can look at my own T1 coronals and see the hippocampal atrophy as easy as possible. And so what you'll see is a loss of hippocampal height in somebody who has Alzheimer's disease. So I referred to this framework a little earlier in the talk, 2018. We took the 2011 criteria and put it together with biomarkers a little bit more effectively. ATN stands for amyloid, tau, and neurodegeneration. Amyloid biomarkers for research purposes are considered to be the low amyloid beta in the spinal fluid, an amyloid PET scan, or the genetic mutations, again, not the polymorphism. Tau, it has to be elevated phosphorylated tau, not just total tau, phosphorylated tau, and some tau PET scans that target phosphorylated tau. N is neurodegeneration, and that's just non-specific findings of any kind of neurodegeneration, atrophy pattern on MRI, hypometabolism on the FDG PET scan, the total tau, you can see total tau elevated in Alzheimer's, but you can also see it elevated in Pick's disease. You can see it elevated in chronic traumatic encephalopathy. So it's not a specific marker for Alzheimer's disease. It's a general marker of neurodegeneration. I think there was actually a study recently that showed that COVID patients had an elevated total tau in their spinal fluid. So it's a non-specific marker of neurodegeneration. And this framework can accommodate new biomarker discoveries. I would love to see a blood test for amyloid or phosphorylated tau. I think that would be wonderful. And I think that would be a game changer. For purposes of the new medicine, you basically have to have either an amyloid PET scan or low amyloid levels in the spinal fluid for aducanumab, which I'll talk a little bit more about later. So here's how you put that together. If amyloid's negative, tau's negative, neurodegeneration's negative, all the biomarkers are normal, there's no evidence of anything. There's a continuum of Alzheimer's disease going from amyloid positive, but T and N are negative, all the way to where they're all positive. And basically the bottom line for Alzheimer's pathology is you have to have an amyloid biomarker. If you don't have amyloid, you don't have Alzheimer's disease. And then if you have evidence of amyloid and neurodegeneration, but phosphorylated tau is negative, that's probably somebody who has a mixed etiology. So somebody who has Alzheimer's and vascular, or Alzheimer's and Lewy body, something like that. And then you can have pathology without Alzheimer's disease. You can have evidence of neurodegeneration and tau, but again, if there's no amyloid, it's not Alzheimer's. And like I said, to qualify for the new disease-modifying therapy aducanumab, you have to have amyloid pathology. So now, how are you going to diagnose dementia due to Alzheimer's disease? You have to meet the criteria for dementia. Memory is the most common, but now we allow for language variants, visuospatial variants, frontal lobe variants. Should not be diagnosed if they clearly meet criteria for another kind of dementia like Lewy body, and biomarkers are not required unless you're planning disease-modifying therapy. So now mild cognitive impairment due to Alzheimer's disease is they meet criteria for mild cognitive impairment, no other etiology. And again, you may or may not have biomarkers, but you will need it for disease-modifying therapy. I will order biomarker spinal fluid testing in somebody with MCI if they want to know what their likelihood of developing dementia in the next 5 to 10 years are. So now that we have all of that, what is preclinical Alzheimer's disease? Somebody who has clear biomarkers or mutations, not just polymorphisms, who are likely to develop dementia in the next 10 years. The next 10 years part is important. We don't want children who have mutations to be diagnosed with preclinical Alzheimer's disease. So it needs to be somebody who's likely to develop dementia in the next 10 years. So somebody in their 40s or 50s. There is no clinically relevant application for this at this time. It is research purposes only. And the current disease modifying therapy, aducanumab, is not tested or approved for preclinical Alzheimer's disease. I wish it was, it's not. Treatment. So I will actually draw this graph for my patients and their families so they understand what their treatment options are. So this is normal aging. We all get a little decline as we get older. We're a little bit less efficient. We're a little slower. But overall, we're pretty close to where we would have been when we were younger. Not a big change over time. This is untreated Alzheimer's disease. First point here, Alzheimer's does lead to death. People die of Alzheimer's disease. And this is not something I hide from my patients and their family. They deserve to know that. People do die of dementia and Alzheimer's disease. From the time of diagnosis to the time of death, the average time is about 7 to 10 years. If we were to start a therapy at that time right there, if it were a cure, you'd go up to normal. We don't have a cure. A lot of times people come to me and they say, I just want something so that I can maintain where I am. If we can maintain function, it would look like this. There is nothing that does this. Nothing. Aducanumab slows the progression a bit. It changes the slope. The way it does this on the MMSE, I believe this study showed that it slows down progression on the MMSE by about 18%. How does that translate? The way I explain it to my patients, if you were going to decline by 5 points in the next 2 years on the MMSE, instead of declining by 5 points, you'll decline by 4 points. That's about all the new medicine does. Wish it did more, but it doesn't. A lot of times people come to see me and think the medicines that we've been using for years, Aricept, Namenda, all of that stuff, slows the progression. It does not. All it does is provide a symptomatic benefit. You get a little bit of a cognitive boost, but the patient will continue to decline at about the same slope as they would have anyway. That's all it does. So, and I make sure that people understand this, because if they have side effects on the drug, I don't want them to feel bad that they're missing out on some sort of miracle drug here. It's not. It's worth a try. We should document that we've tried, that we've discussed it. But if they don't want to take it, or if there's just too many side effects, it's okay. It's not the end of the world. We're all pretty familiar with all of these: donepezil, rivastigmine, galantamine. We used to tell people to take it at nighttime because it does cause a lot of stomach side effects. But the problem is, if you give it to them at night, then they'll have lots of vivid dreams and they won't sleep well. So I usually give it in the morning, and I start it at low dose and slowly increase it over time. And some people, it increases anxiety and agitation. And because these are cholinesterase inhibitors, it's increasing the amount of acetylcholine in the body. It does slow down heart rate and cause bradycardia. So if somebody has a prolonged QTC, I do try to look at EKGs whenever they're available, or if they're on a lot of other medicines that slow down heart rate, may not be the best choice for these folks. The other drug is Namenda, memantine. It's an NMDA receptor antagonist. It's meant for moderate to severe Alzheimer's disease only. And it really doesn't have a lot of side effects, but so I give it a try. It's fine. Aducanumab is the first FDA-approved disease-modifying therapy for Alzheimer's disease. And I'm not sure how many folks have been paying attention, listening in on me when my phone calls with Biogen and my discussions with patients, but it is a very controversial medicine. The reason why it was controversial is because the advisory committee for the FDA told them not to approve this drug. It's not helpful. Yes, it treats biomarkers. It absolutely does remove amyloid from the brain. And it seems to slow down phosphorylated tau in the spinal fluid. So it treats biomarkers really well. But for an 18% slowdown on the MMSE, I'm not sure that I was really all that helpful. And so there was just not enough evidence for the advisory committee to agree to think that this should be approved. Some sort of behind the doors, back room, smoky rooms kind of discussions happened. I don't know. And the FDA approved it anyway. and that was where we got into trouble last June when everybody kind of went crazy. Yeah. So it cost originally $56,000 a year. And we weren't sure if Medicare was going to pay for that. Then everybody found out about the controversy about the advisory committee and whatever. And so now there's an investigation to see if there were any improper contacts between the FDA and Biogen to get this drug approved by the FDA. And Biogen got a lot of bad press for it, and deservedly so. And so they cut the price in half from $56,000 to $28,000. Still a very expensive drug. There was an analysis that showed that based on whatever they did show for the drug, that maybe it was worth about $8,000 to $10,000 a year, but it certainly wasn't worth $28,000 a year. If you model it out, if you statistically say, okay, you have all this slowdown in cognitive decline, in theory, it slows down progression on function and behavior. Maybe you're reducing nursing home placements and so on. Maybe it's worth about $8,000 to $10,000 a year, but not what it is, what they're pricing it at. The other problem with it is that when do you stop it? Are we going to be giving them a $28,000 a year drug for the rest of their lives? The FDA was not clear on when you stop this drug. So we have no guidance whatsoever on when you start and when you stop. So there's all of that. So hot off the presses last week, the CMS decided that they're not going to pay for this drug unless somebody's in a clinical trial. So you have to be in a randomized clinical trial. And then CMS will pay for an amyloid PET scan and for you to get this drug. It's been I reached out to my Biogen rep to find out what they're going to be doing next, and it's been radio silence. I suspect there's a chance they're going to withdraw it from the market, because why would we continue to promote and produce a medicine that we can't get paid for? So I don't even know if this drug is going to be around in a few months. But again, the way it works is it removes amyloid. And in theory, if you remove amyloid soon enough, you can slow down some of the tau degeneration in brain. The problem is that it's only FDA approved for MCI and dementia. We still don't have anything FDA approved for that preclinical phase when I think it would be the most helpful. So I personally think we really do need a blood test that helps to find amyloid and phosphorylated tau in the bloodstream in people who are normal. And then you can escalate from there and treat somebody with one of these monoclonal antibodies, maybe not aducanumab, maybe something else. But that's really how we're going to beat this. I don't know how we beat it waiting until mild cognitive impairment and dementia. So what do we tell our patients and their caregivers? We want to give them honest answers to the three questions. Is there memory loss? Is it a dementia? Is it Alzheimer's disease? We want to make sure, maybe not in the very first visit, but maybe in the first 2 years, that they understand that dementias are degenerative illnesses that do eventually lead to death. And the reason why it's important for them to understand that is because a lot of folks, even though they're mild cognitive impairment or mild dementia, they still have testamentary capacity. They could still do a will and a trust and an advance directive. We need to make sure they know that when they're mild and still capable. Because we've all seen the horror show that it is when somebody does not have their advanced directives and they've lost capacity to do their advanced directives, and then the family is scrambling. It's a real mess. So it is important to find out if they have mild cognitive impairment or mild dementia so that you can point them in the right direction and make sure they get these things done sooner rather than later. Because if you wait too long, that's it. I do try to give them, I'm not Sarah Hines, I'm not a social worker, but I do try to point patients and family in the direction of resources like the Alzheimer's Association, Lewy Body Association, because Lewy Body has so many behavioral issues. They have a lot of great resources on managing behavioral problems in dementia. And then I also try to ask my caregivers to get the book called The 36-Hour Day, because that's basically what a day of taking care of a dementia patient feels like. So in conclusion, we want to use criteria to identify people who have neurodegenerative etiologies of mild cognitive impairment and dementia. We want to be able to identify people who would benefit from clinical trials. We want them to evolve so that we can incorporate new discoveries in Alzheimer's biomarkers like blood studies, like there's retinal scan. Maybe there's a retinal scan that can look for amyloid in the retina. Something like that can help us diagnose this sooner. We want to know how to appropriately use biomarkers and disease-modifying therapies when they're available. We don't want to ignore the patient. We don't want to forget the caregiver. We need to address both. I kind of think of having two patients in the room at once when I have somebody to come and see me, because I have to address both of them. And that's it. Any questions? Yes.
In regards to when you're looking at a patient, what would you say is your marker for they have vascular involvement or not in their brain?
It's the MRI.
Yeah.
So a little bit, and it also depends on their age and their history, but if there's a significant amount of white matter disease, then I'll probably say they do have some mixed vascular pathology. The older they are, the more likely they are to have mixed pathologies. Pure Alzheimer's disease is actually pretty uncommon. You're really going to only see pure Alzheimer's disease in your 60-year-olds, maybe your 70-year-olds. When you get into your 80s, the chances that you have pure Alzheimer's with no vascular is pretty low. Vascular tends to be a lot of it.
On one of the slides, you gave us a P1 chronal of an Alzheimer's patient versus a regular patient. You mentioned that people can go shortening, but I also noticed some enlargement of the lateral ventricle of the Alzheimer's patient. I was wondering if that's significant to Alzheimer's or just atrophy in that particular patient.
Let me get back to that slide so I can take a look. That's sort of I was just pointing out the hippocampus, but you're right, there's a generalized atrophy here throughout with enlarged ventricles. So this person has both central and neocortical atrophy, not specific to Alzheimer's disease, other than the general atrophy that happens in Alzheimer's disease. All right.
Thank you.
Thank you. Thank you for coming.
I'm just glad that people like you would exist.
I think this needs to be like, you know, you're gonna get your certain age, okay, you gotta get your colonoscopy.
Yeah, you gotta get
Just
your
get an dementia screen, yeah.
There's gotta be a blood test. Who's gonna do a spinal tap on every